Hello guys, good evening everyone. Am I clearly audible and visible to you? Let me know in the chat box. Let me know in the chat box guys. Am I clearly audible and visible to everyone? Then we'll start the session. Okay. Yes, yes. We'll provide the PDF directly on the Telegram group of Meduhub. You will get the PDF, no issues. Okay. For this session, we are keeping for a shorter period, like for the 2 hours only, right? I'm not going to take the prolong of this. I already told you, doctor, will give you the PDF on the Meduhub Telegram channel. Good evening, good evening. Okay, okay, doctor. So you can check the Telegram channel of Meduhub and you will get the PDF from there only. Clear? Right. So what is the today's sessions? We are talking about it. Part 2 will be also there. Part 2 will be also there soon. Okay. Part 2 will be also there shortly. Uh, Doctor, exactly, I cannot say to you that how many questions are coming from here. Like it will be a very controversial question. But I can say you this for the basic and the importance of your ophthalmology, the topics will be going to cover over here. All right. I cannot say directly like how many questions can become from this session. I'm not giving you this surety from this session, right? But yes, the almost we're going to cover up the important topics. This is the main. Sure. Let's start. Not wasting the time, and we'll start with the like basics. I'm little bit covering the basics because many of the students are requested me that we didn't had anything in the ophthalmology. Just we gone through some notes and everything. So that's why I'm little bit covering up the little bit of your anatomy of the eye, and then we'll directly jump up to the diseases of the eye, right? Which is the most important and frequently asked to do diseases. So we'll be going to cover up those only. All right. Okay. So let's before starting this, I will share the link to the group again. Let's everyone join who left. So we can start the session, right? And all should be joining the live, so it will be much better for them also. So if they will join, it will be helpful for them. All right. Okay. Okay. Now, so starting with this session and going through the first, starting with your anatomy of eye. In the anatomy of eye, guys, we are going to start with the first about the eyeball. Of course, in the eye we have the eyeball and the nearby structures. So we will going to talk about in the later. We're going to talk about the nearby structures also. First of all, we have to talk about your eyeball, right? Now in the eyeball, what it's comprise. Okay, so please remember about it. I always give you the same example, right? Your eyeball is having the three layers. It is a globe like structure, we can say a ball like structure. Okay, so it is a very big ball like structure and it is having over there the three coverings. What it is having? It is having over the three coverings, right? And this three coverings, like the outermost is your fibrous coat, right? Then it between it we have the vascular coat we are having, and the last one we are having the your nervous coat, right? So we have the three codes over there. So we talk about one by one about the all the codes. Okay, we're going to talk about the one by one about the all the codes. Let's start with the first one. So the first one is the your eyeball comprised with the three codes, and out of these three codes, the first one is your fibrous code. Write down here, guys, outermost. Okay, so this is the outermost layer, right? And in this outermost layer, what we have? We have the two important structures. The first one, which is the cornea, which is a transparent anterior 1/6 structure. Okay, so you guys can see over here, I am marking with the red color this number one. So you can see over there this transparent 1/6 structure for outermost layer, which is the fibrous coat. This is known as your cornea. Okay, and now what we left? We left behind. If we are talking about the anterior most, the 1/6 part is the anterior most 1/6 part is your cornea. What about the posteriorly? So posterior 5/6 part, you can see this yellow color one. This posterior 5/6 part is the your sclera. Okay, so this posteriorly 1/6 part is your sclera. And please remember, guys, the important, this is the opaque. So what do you mean by this opaque? That this is the your not the transparent. Okay, it's not the transparent. What about the your anterior, which is a cornea? Cornea is the transparent. Okay, cornea is the transparent. And now, if it is a transparent, guys, please remember about it. If it is a transparent, so now what will be going to happen? In this transparency, it will be going to make use of the refraction. Okay, so the cornea will be going to use for the refraction. The cornea will be going to use for the refraction. Now, the important thing, what we have to talk about, which is the third one structure, or just we can mark it with the Roman one, right? What is this limbus, guys? Important. When we are going to talk about the diseases, we're going to see about the limbus, right? We'll clinically mention the limbus is having this structures or seen this symptoms on the limbus. So what is the limbus, guys? So of course, there will be the meeting junction over there. Of course, as this is the starting, the anterior part is the your cornea, and from the posteriorly there is a sclera is coming. So of course, they will be going to meet over a junction. All right. So you can see over here, I'm writing with this Roman one here. I'm marking on the diagram. So you can see over there, this is the limbus. Okay, this is the limbus. And what is this limbus, guys? Please remember, the limbus is over the junction of cornea and sclera, where the conjunctiva will be going to attach. When we are going to talk about the conjunctiva, so the conjunctiva will be also going to attach at the limbus, right? So now, please remember, so this is the area where your sclera and the cornea will be going to meet over there. So right, you can see in your eye also when you are standing in front of your the mirror. So you can see in front of that this is our transparent is the cornea, and the near translucent white color is the our sclera is seen, right? So where they are meeting, right? Where they are meeting, that is your limbus. That is your limbus, right? So this is the outer coat. So from the outer side, we covered this much, that there is a three structures we are going to talk about in the outermost. First one, which is the anterior 1/6 part, transparent, it will be the transparent structure. Also, if we are talking about it, it will be the transparent. And what will be the importance of this structure? It is your anterior 1/6 part. It is covering your anterior 1/6 part. Very good. Now, moving forward, the vascular coat. Now we are moving forward for the vascular coat. What will be going to see in the vascular coat? It is also known as, guys, your uveal tissues. And what we are having in this structures, again, we have the three structures over there. The first, iris, second, ciliary body, and the third is your choroid. Now, starting with the first one, which is the known as your iris, so it is a middle layer. We can write here the, okay, so this is the your middle layer, right? This is the your middle layer, and now this middle layer will be going to start with the iris. So you can see over there, just behind this, just behind the cornea, we have a colorful structure. This is known as your iris. So I'm marking with it with black color one. Okay, so you can identify the middle coat with the black color. or we can say the vascular coat. I'm writing here like black color, so you can identify. So this is the iris, which is you can see over there. And what is the use of this iris? Please remember about it. It is a colorful structure, so it is making for the identification. I hope you can study this identification in your FMT also. And I hope you remember, guys, you all are Aadhaar card holder Indians, right? So when you visit for the Aadhaar card, right? When you had got their Aadhaar card, so they had your iris scan over there, right? So what is this iris scan? So every person is having the different irises, right? As we have the fingerprints, right? For the identification, right? We have the different for the identification. We have the different fingerprints, right? The same thing. We have the different iris scan. So this is can be used for the identification of the person, right? Okay. Now, moving forward for the second one, which is the your known as a ciliary body. And what is the ciliary body, guys? Our ciliary body is having the two parts. The one is the pars plicata, and the second one is the pars plana. Okay, so we have the pars plicata and the pars plana. So the ciliary body is here. You can see I am marking with the black color in the diagram with the numbering 2, and you can see over there this is the ciliary body, the anterior part. Please remember this pars plicata is the anterior one and pars plana is the posterior one. Okay, so the anterior one and the posterior one. Right. So the pars plicata is the anterior one. So if I'm talking about it near the here, iris is going to attach over the pars plicata part, and the posteriorly we have the guys pars planal part. Okay. So we'll talk about in the later when we are talking about the aqueous humor. We're going to talk about this. Okay. The next and the last of the middle layer is the choroid, right? So we have the last, which is the choroid. And what's the important about this choroid? Okay, so this choroid is the posterior one. Okay, so you can see the ciliary body is ending here, and this posteriorly going this red color vascular coat is the your choroid. Okay, and this choroid is what? This choroid will be going to just lying lying down on the your retina, and what it is help, it helps the nourishment, it is giving the nourishment to the your retina. Okay, so it is giving the nourishment to the retina. Okay, now as it is a vascular, so it is having the arterial blood supply also, venal blood supply also, right? So this will be going to give the nourishments and nutritions to the your retina. Okay, and that's why as we talked about it, it is a highly vascular and the supplying the nutrition to the outer layer of the retina. Now going inside with the third one is the your nervous coat, which is also known as the retina. And please remember about it, the important of it, that this layer is only the responsible for the visual functions. And we have the two structure over here, the first one which is the retina, and the second one which is the your optic nerve. Now in the retina we have the all the 10 layers. The first one layer is this, right? The retinal pigmented epithelium, and the rest of the 9 is the known as the neurosensory retina, right? Rest 9 layers. Okay, rest 9 layer is known as neurosensory retina. So we have totally here 10 layers of the retina, right? So this 10 layers of the retina will be the inner, will be going to make the your nervous coat, and this is the your first structure of your nervous coat, which is the retina. And now the bundle of axons of this your retinal neurons will be going to exiting this eyeball as a optic nerve. Very well, right? This is your second cranial nerve, right? olfactory, optic, right? I hope you remember about it from the anatomy. The first one is the olfactory for the smell senses, and the second one is for the optic for the vision, right? So this will be the your exiting as a your nerves of optic nerve, right? So I hope now you understand with this all the structures that we have to cover up here. We covered here, guys, your all the three layers: the fibrous coat, the vascular coat, and the nervous coat. Okay, we covered this all, right? Now we are moving forward, right? Now I'm covering little bit basic because, guys, later in the diseases we're going to talk about this layers, right, with this structures. So maybe you guys don't know this basics. That's why I'm covering this much. Okay, now we covered with the layers. There was a three layer. Now we are talking about the contents. Okay, now we are going to talk about the content. So the again content is also the three. So the layer was the three and the content was also the now the three. The first one is your the crystalline lens, which is very important as for the disease aspect. Also, we are going to talk about the more about the lens in the cataract, right? The second is the your aqueous humor, right? It is a fluid, water like fluid structure which is covering your most the anterior part of your eye. And the third one, which is the vitreous humor, this is a gel like structure which is covering the most of the part of your eye, which is filled with the posterior segment. Now, for understanding this, I have to go through with this diagram and I have to explain you the two things. Just go through with this thing because this is a very confusing thing. The students are not understanding. I don't know why, but it is a very easy thing which I'm going to cover up here, covering up here. Just listen this part, guys. I have to divide my eyeball into the two parts, right? So as I'm dividing this my eyeball into the two parts in the anterior and the posterior. So what I did, I make a imaginary line. Let's draw an imaginary line. It will be helpful for us, right? So for drawing this imaginary line, I'm drawing this imaginary line over the landmark. And what is the landmark for this drawing this imaginary line? That is your crystalline lens. Okay, so this is an imaginary line which I drawn on the basis of your on the basis of your lens, right? So this the lens is the landmark, guys. Please remember about it. I'm clearing you the very very good aspect. Just listen this part, okay? It is a very important. Now, as we covered up this, now that here we have the posterior one from this line. How much is the posterior one? This is known as your posterior segment. Okay, this is the posterior segment. Okay, and whatever is the in front of it. Now, this is known as your anterior segment. Okay, so we have the posterior side, posterior segment, anterior side, we have the anterior segment. Any doubt in this? So if I'm talking about the segmentations of the eye, so we can divide into the two segments, anterior segment and the posterior segment on the behalf of lens. So just write down with me a schematic diagram which I'm going to cover up here. Just write down, guys, that write down here eyeball, divide into the two parts, anterior segment, posterior segment, and write down here lens. Why I'm writing the lens here? Because the lens is the landmark from which I'm dividing the anterior and the posterior one. Okay. Now, what happened with this next? Our anterior segment is going to further divide it into the two parts. And what are those two parts which is further divided? The first one is your anterior chamber and the second one is your posterior chamber. Okay. One is the anterior chamber, and the second one is your posterior chamber. Now, if I'm talking about it, right? If I'm talking about this chambers, how it is divided. So just write down here also. It is divided on the base on the iris. It is based on the landmark is what? Your iris. So now just zoom into it, and whatever we have to divide, please check it out. I'm drawing with the different color, which is the black color. I'm again drawing an imaginary line, and this time this imaginary line is on the basis of iris. Okay, I divided this on the basis of iris, and on the basis of iris, this divided, right? This divided the anterior segment into the two part. So this one part between the cornea and the iris, it is known as anterior chamber, and whatever is the rest behind this one, from this line to this imaginary line, or we can say between the iris and the lens, this will be known as your posterior chamber. Posterior chamber, right? So we are done with this. I hope you remember with this easy trick and the schematic diagram which I given to you, that how this eye is divided. So totally the eye is divided into the two segments and the two chambers. So what are those two segments? The anterior segment and the posterior segment. And the anterior segment is further divided into the two parts, which is your anterior chamber and the posterior chamber. Now, moving forward. Now we are moving forward. As we completed with the chambers and the segments, now you guys can understand about very well about your aqueous humor. Now, what is the importance of this aqueous humor, guys? Please remember about it, that this is the this is your water fluid light which is filled in the your anterior segment in the eyeball. So I hope you understand about it. What is the anterior segment? Between the cornea and lens. Whatever this area, this is fully filled with your watery fluid, and that fluid is known as your aqueous humor. That fluid known as your aqueous humor. Now, what is the importance of this? Please remember, this is a transparent. What is the importance of it? It is a transparent. As it is a transparent, so please remember, it is work as a refractive medium. So it work as a refractive medium. Guys, what is the meaning of a refractive medium? Let's go through this, right? Let's highlight and go through this. Let's talk about it. What is important about it? That refractive medium is that when light passes into eye, it crosses the structures known as refractive medium. And guys, please remember about it. So you have to remember, we have the four refractive mediums. As the light is coming from anterior side, guys, please remember about it. As it is coming from the anterior side, first of all, it will be going to penetrate your cornea. So just I'm going to show you again from this diagram. You can see if the light is coming from this side, okay, so it will be going to, first of all, it will be going to cover your cornea, right? So this will be your first structure, which is the refractive medium, is your cornea. The first structure is your cornea. Okay, just a minute, guys. Okay, the first structure is your cornea. Now, after this cornea, guys, now after this cornea, now you guys can see here, what you guys can see here, what about after this cornea? Just behind this, we have the your anterior segment. And what is the field with the anterior segment? As we already know, what we have the aqueous humor. Behind this aqueous humor, as we divided this as anterior and posterior segment on the basis of lens. So this lens is also transparent. The light will be going to pass through here. And the last is your vitreous humor. And this will be the your all the refractive medium, right? So I hope you understand the basic of this refractive medium. What is the refractive medium? As the light is passing into the eye, it crosses through the or it passes through the several structures. Those structures are known as refractive medium. Those structures are known as refractive medium. Now moving forward about the aqueous humor, guys, please remember this aqueous humor is produced by your ciliary body, right? So which is the middle vascular coat. We talked about this middle vascular coat, the second structure, iris, ciliary body, and the choroid. So the ciliary body, which is the middle structure, it is going to produce your it will be going to produce your aqueous humor. Now, what is the importance of this and why we are talking about this so much about the aqueous humor? Because in the later part, in the glaucoma disease, right, this will be the very important. Okay, now what will be going to happen with this? This is going to drain mainly from the your angle of anterior chamber. We talked about it, the anterior chamber. And what is the anterior chamber? This anterior chamber is the your between the iris and the this is the iris and this is the cornea. So this is the anterior chamber, and guys, please here, this is the angle, right? So this is the angle, or this is the call as angle of anterior chamber. Okay, this is known as your angle of anterior chamber. So from here the your aqueous will be going to drain. Now what is the aqueous pathway? Just listen this part. As we talked about it, it will be going to produce from where? It will be going to produce from your ciliary body. So it is coming from the ciliary body and reach to your, first of all, it will be going to come to your here. What is this structure? This structure is known as your posterior chamber. Okay, this structure is known as your posterior chamber. From this posterior chamber now, from this posterior chamber, this aqueous will be going to pass from this in front of lens and come to the your from the posterior chamber to anterior chamber. As it is going to reach into the anterior chamber, now it will be going to flow and reach to your angle of anterior chamber. At this angle of anterior chamber, we have the Schimm's canal, or we can say the your canal of Schimm's. From this canal of Schimm's, it will be going to drain out, right? So the aqueous is producing from the your ciliary body and going to drain out from the your anterior chamber from the Schimm's canal, or we can say the canal of Schimm's. And what is the importance of this? Please remember, it will be going to maintain your intraocular pressure. So as the eye is a packed structure, right? So we have some fluid inside it, and this fluid will be going to make pressure over the wall of the eyeball. So that pressure is known as your intraocular pressure. As we have the intracerebral pressure, so what we have the fluid filled in the brain, which is known as CSF. So the CSF is making pressure over the walls of the brain, that is known as your intracerebral pressure. Okay, the same the intraocular. So inside the eye we have the filled this fluid, aqueous humor and the vitreous humor. This will be going to this in your aqueous humor and the vitreous humor will be going to making pressure over on the eyeball walls of the eyeball, and that is known as your intraocular pressure. Short form, we are saying to this intraocular pressure in the normally IOP. Okay, and just write down about the intraocular pressure. What is the intraocular pressure normally? So the normal intraocular pressure is your 10 to 21 mmHg. Okay, so we have the 10 to 21 mm of Hg, the 10 to 21 mm Hg of the, your intraocular pressure, right, which is the normal. Just write down here the normal also. Okay, now what is the use of this aqueous humor? Please remember about it. The aqueous humor will be going to do the providing the nutrition and remove the waste product from the your anterior chamber. Okay, so it is coming like that, and it will be going to provide the nutrition to the your cornea, right? as the cornea is the avascular structure, so the cornea will be going to getting nourishments, getting nutrition, right, from this aqueous humor, and whatever the waste product is there, it will be going to removed by this fluid only. So this is about the your aqueous humor. Now talking about the next, which is the vitreous humor, and as please remember, aqueous is in the anterior. Okay, so the vitreous will be in the posterior segment. So whatever the posterior segment, whatever is behind the lens is totally filled with your vitreous humor. It's totally filled with your vitreous humor, and this vitreous humor, please remember about it. This vitreous humor is the your gel-like structure, right? As it's clearly mentioned here, it is a gel-like substance, right? What it is? It is the your gel-like substance. Now, as it is a gel-like substance, just a minute. As it is a gel-like substance, this is going to fill the your posterior segment of the eye. It will be going to fill the your posterior segment of the eye. What about this also? This is also the transparent as we talked about it. So that's why this is also function as the your refractive medium. So what we talked about the four refractive medium: cornea, then aqueous humor, then lens, and the last one was your posteriorly what we have, the vitreous humor. So this is the also your refractive medium. What is the importance of this? This is giving the eye a structural support. So the vitreous humor is providing the your structural support to the eyeball, and that's why it helps to maintain the shape and the contour of the your eyeball. So it is going to making the round, as we have the round eyeball. So for the making this shape, right? So keeping this shape is the use of your vitreous humor. And next, intraocular pressure. Intraocular pressure. Of course, as I already told you, as the fluid which is filled inside your eye, it will be going to make pressure on the wall of the eyeball as the aqueous was making. So of course, the vitreous is also filled in the posterior segment. It will be also going to make the pressure over it, and that's why this is also contributes in the maintaining the stable intraocular pressure. So this is also stabling the IOP. Okay, so it is also making the stabilization of the IOP. Rest about the lens we are going to talk about in the chapter of the cataract. Let's move forward. And now some important values, guys. Please remember about this important values. What are these important values? Please remember about it. These important values are the of the eyeball. Okay, so these are the important values of the eyeball, like the basic: what is the length of eyeball, what is the width of eyeball, what is the height of eyeball. So this is general question. Sometimes they can ask you in your exam as MCQ, right? They can ask you, oh, what is the length of eyeball, right? So it can be asked. So just remember about it. So the length of eyeball is just 24 mm. And if we're talking about the width, okay, so length, if I'm talking about it, it is from the anterior to posterior, and also known as axial length. Okay, this is also known as your axial length. Okay, sometimes they ask what is the axial length of the eye ball. So just remember about it. This is also known as axial length. Now, if I'm talking about the width, what is the width? Width is the your 23.5 mm, and this is from the your lateral to medial. I hope if you studied well your if you studied well the your anatomy, I hope you can understand from the anterior to posteriorly it is going. It is your length, right? What about the width? Width is like that. If I'm talking about the medial to lateral or the lateral to medial, so that will be your 23.5 mm. And the last is your height. Height is your 23 mm. Just write down here mm, right? This 23 mm, and this is from the your superior to inferior, like from here to here. If I'm talking about like this, right? This is a three-dimensional structure, right? So the height is 23, width is 23.5, and the length is your 24. So just remember about it, LWH, and remember just the one, and then decrease the point 5 and you will be going to get this set, right? Low but low weight, your length, width and height. Okay, now the last is the volume, is the 6.5 ml each eyeball. Please remember guys, it is a each eyeball. Okay, and what is the weight of it? The 7 gram is each eyeball. Okay, the 7 gram of each eyeball. Okay, so the weight is 7 gram and the volume is the 6.5 ml. Okay, so this basic they are asking you sometimes, so just remember about it. Now we are moving forward. We completed the anatomy of the eyeball, right? So we covered with the anatomy of the eyeball. Now we guys are moving forward for the next one, which is the diseases of your cornea. Very commonly they can ask you the corneal diseases, and most commonly they are going to ask about in the cornea, they are going to ask you about your corneal ulcers, right? Differentials between the corneal ulcers. So let's talk about this cornea and the corneal structure. So before going to the cornea diseases, we are just going through the your corneal layers. So we have the totally how many layers we are having guys? Earlier it was 5. Nowadays we have the 6 corneal layers, and what is the new layer we have added? This is the your Duas layer. Okay, this is the newly added layer, which is the Duas layer. And if we are talking about it with the diagram, you can see over here we have the first outermost layer, which is known as epithelium. After that, we have the next second layer, which is known as Bowman's membrane. Bowman's membrane. And the third one, which is your stroma, which is we can say the thickest layer. Okay, this is your thickest layer, stroma. Then here we have between this stroma and descendant membrane, we find a one more new layer, which is known as your fourth layer, which is Duas layer. Duas layer. And the fifth one is your descendant membrane. This is your fifth one is the descendant membrane. And the last one, which is the innermost, it is your endothelium. Just mention here in the endothelium, what we have in this endothelium, we have a pump for the nourishment of the it, which is known as your sodium, potassium, ATPase pump. Just remember about it. What we have over here, we have the sodium, potassium, ATPase pump in the endothelium, in the endothelium of your, yes, it is by the Indian scientists. Very good, doctor. Yes, it is by Indian scientists only, which is the Duas layer, right? Very good, right? And this is the from the your endothelium. Let's talk about what is the blood supply, right? So what we have the about the blood supply, please remember the cornea is your avascular structure. The cornea is your avascular structure, and that's why the nourishments or the nutritions are coming from the your diffusion through the your aqueous humor and the from the peripheral vessels. So it is not having any blood supply. The cornea is not having any blood supply. It is getting the your nutritions from the your aqueous humor and little bit from the your peripheral vessels. That's why only the aqueous humor is providing the nutrition to the your cornea, right? It is providing your nutrition to the cornea. And what is the importance of it? Please remember, if your cornea is the vascular structure, it cannot maintain the transparency. It will be not remain the transparent, right? Because the vessel will be going to pass through it. Vessels will be going to pass through it. If the vessel is going to pass through it, it will be not remain the transparent. The next, what about the nerve supply? The nerve supply is innervated by the your anterior ciliary nerves. We're going to talk about this innervation of this anterior ciliary nerves in the neuro-ophthalmology. and this will be going to make the three plexus within the cornea. So it will be going to this, your anterior ciliary nerves will be going to come over there and forming the three small plexuses will be there and for the supplying your cornea. What are the functions of the cornea, guys? Please remember the corneal functions are, your major function is your refractive medium. As we talked about it, the first refractive medium is your, like if the light is coming into the eye, it will be going to pass through the first structure. What is the first structure it will be going to pass? Of course, it will be going to pass through your cornea only. So the first one is structure is known as your refractive medium, which first refractive medium is your cornea only. The next, please remember, it protects the intraocular contents. Of course, that is the fibrous coat, we talked about it. The fibrous coat is doing what? It is covering your outer part and helping to the maintain or the protect the intraocular contents. Within the next, with the transparency maintained by the lamellar arrangement, and it transparent through this three important properties, which is the laminar arrangement. Second is the avascularity, no blood supply, and the third one is the your dehydration. Okay, this is the known as your dehydration. This three is important. These three important things are making your cornea transparent, right? This is the making your cornea transparent. Now, moving forward, just with the some more corneal functions. First is the transparency. As we talked already about it, it maintained by the your collagen arrangement, which is the lamellar arrangement, avascularity, and the dehydration. The nutrients are coming from the your oxygen is from the your air via the tear film, and please remember the glucose is coming for the energy production. The glucose is coming from the your posterior part aqueous humor. Okay, so this is from the air anteriorly from the outermost from the air it is coming, and the aqueous is supplying this glucose from the posteriorly from the behind. Okay, now we are moving forward for the next disease, we can say, which is known as your bacterial keratitis. Guys, please remember keratitis, it means the infection of cornea. Okay, keratitis, it means your infections of the cornea. And we're starting with the first one, which is the bacterial. By the name, you can understand, guys, what will be the cause of this disease. Of course, the bacteria will be the cause of this disease, right? As clearly mentioned, that bacterial keratitis. Also, it will be going to cause the ulcer over the cornea, right? What it will be going to cause it? It will be going to make the ulceration over the cornea. So that's why it is known as your bacterial corneal ulcer, right? That's why this is known as your bacterial corneal ulcer. Now, what will be the infection sources, guys? How this bacteria, how this infection will be going to come and infect us? So the infection source is from the infection sources are coming from the your exogenous. What is the exogenous? From the outside, like your foreign bodies, or maybe from the your contaminated water. Can be spread from the nearby ocular tissues, like maybe it having the conjunctiva is having some bacterial issues, or maybe the sclera is having the bacterial issues, and this bacteria can go to the nearby organ or the nearby structure, so that can be go to the your cornea also, so that can cause your bacterial keratitis. And the last one, which is the your endogenous infections, these are the very rare. It is saying like some patient is having the endogenous any internal bacterial infection, and that can spread to the eye. It is very rare. It is very rare. All right. Some systemic factors are also available for this your bacterial keratitis. And what are your this systemic? What are those your systemic factors? Like the first one, which is your immunocompromised state. So if any person, it is the immunity is very low, immunocompromised, and you know very well what are the example of your HIV/AIDS, diabetes, pregnancy. These are the immunocompromised states are over there. And also the systemic, the second systemic and important feature is the your malnutrition. I hope you know very well about the eye nutrition. If we are talking about the eye malnutrition, there is a very common disease which is the your vitamin A deficiency, right? Vitamin A deficiency, which is leading your keratomalacia, yes, destruction of the cornea, right? Destruction of the cornea. It is caused by your vitamin A deficiency. Also, we can see over there what can be the other risks, right? What can be the other risks over there? There is a use of corticosteroids. There is a use of the corticosteroids. They are the maybe the person is using the prolonged use of topical or the systemic corticosteroids. If the patient is having the prolonged use from the several months, is putting the eye drop of your corticosteroids, or maybe using the tablet form for the systemic corticosteroids, like the patients are having for the knee pain, joint pain, right? So they are having the systemic corticosteroids, can be increase the risk of your bacterial infections. As you know very well, the steroids are doing what? Steroid is doing the suppression of the our immunity, right? So as the immunosuppressant, it is working. So as it suppresses the immunity, so there are the more chances to get the bacterial infections. What are the your causative organisms? Our causative organism is, guys, here commonly is your Staphylococcus aureus. Okay, and you can see over here the patient is having a ulcer over the cornea. Okay, the patient is having the ulcer over the cornea. Now, what are the symptoms will be seen in this patient? Please remember, the first is the pain and the foreign body sensation due to the mechanical and some chemical irritations. And what kind of this mechanical and chemical irritations? The patient is feeling the pain and foreign body sensation. The foreign body sensation, the patient is feeling like that some foreign bodies fall into the eye. Okay, it feels like that the some foreign bodies inside the eye. The next is the watering. And which kind of watering? Please remember, lacrimation is seen over there. And why the lacrimation is seen over there? Due to the reflex of the hyperlacrimation, due to the reflection of your reflex, right? So our eye is giving the reflex to it, and the eye is reflecting. I hope you remember some foreign body. If the some foreign bodies fall into the your eye, right? If some foreign bodies fall into the your eye, you can see over there what is happening through this. That there will be the your just a minute, guys. There will be the your eye will be going to give the your sensation, which is the your foreign body sensation, right? It is giving you the foreign body sensation, right? The same thing, the same foreign body sensation we are talking here, right? The same foreign body sensation we are talking about here. Just a minute, guys. Now, this foreign body sensation will be felt by the patient. Okay, so this foreign body sensation will be felt by the patient. The next thing, what will be the more? There will be the scene, the patient will be going to feel the your photophobia. And why the photophobia? The patient is a very light sensitive due to the nervous stimulation. There is a nervous stimulation, and due to this, the patient is very light sensitive. So the patient is having the fear to go into the bright light. Also, the patient is having the blurring vision. And why the blurring vision? Because of the caused by the cornea is hazy. So there is the if the cornea is hazy, the light cannot pass. Right? So the refractive medium is hazy. Just write down here, refractive medium is hazy, right? So as the refractive medium is very hazy, right? So there is a no passing of the light into it. The next and the last, which is the your redness of eye from the your circumcorneal vessel will be going to congested, and due to this there will be the redness will be seen, right? Circumcorneal, the near the cornea, because the cornea is a vascular structure, but nearby the cornea, whatever the vessels are there which are having the making over the circumcision, right? On the circumcision, the corneal vessels, they will be going to congested, and that's why the redness is seen. You guys can see over here the eye sclerize totally see the redness, okay, near the cornea. Now, moving forward for the sign, what kind of sign is there? There will be the seen swollen eyelids. The patient is having the swollen eyelid. Also, there will be the seen the baphlospasm. Guys, what do you mean by the baphlospasm? This is the involuntary lid closure, right? The patient don't want to close the eyes, but it is an involuntary closing of the lid or the eyelids, right? That is known as your baphlospasm. Also, it is next is the conjunctival chemosis and hyperemia. And conjunctival chemosis, so some of the chemicals will be going to release from your ciliary congestion, right? And hyperemia, hyper is more emia, means known as the blood. So there will be the more blood will be going to flow in this. So by this, there is the red conjunctiva with the your ciliary congestion will be going to seen in this. The next, and which is a very important, what kind of the corneal ulcer will be going to seen in this? Okay, what kind of the corneal ulcer will be going to seen over this? Now, starting with the first one, that in the early stage it is involving your epithelial defect with the grayish whitish infiltrates in the starting of it. But as it is established, now it will be going to convert into the yellowish whitish color, and also the shape will be the your oval or irregular shape ulcer. Okay, this will be making your oval or maybe irregular shape ulcer. But remember about it, the shape is irregular, but have the clear cut margins. Okay, so it is having the clear cut margins. It means I can identify the margins of it. For the ulcer, I can identify the margins of this ulcer, that yes, in this area the ulcer is growing. Okay, and the last, what is the treatment, guys? As you know very well, it is your bacterial infection. So of course we have to give the antibiotics. What we have to give the antibiotics? So we can give the antibiotics in the tropical form, and the tropical form is also we can give in the eye drop. Okay, we can give into the eye drop, and ointment also we can give. So the we can give the moxifloxacin, also we can give the gatofloxacin. Okay, gatofloxacin. So two things we can give. Also the patient is having the severe pain over here, so for the pain relieving we can give the atropine. Okay, right, for decreasing the pain sense. So atropine is doing what? Atropine will be going to dilate this iris and decrease the pain of the patient, right? So these two things we can give over there. Guys, please remember, in the bacterial ulcer we're going to give no steroids. Okay, why we are not giving the steroid, guys? I already told you the steroid is the cause of it. Okay, so we are not going to give any steroid in this condition, right? So I already written over there, no steroid should be given in this condition. Clear? Please remember, don't mark the answer the steroid in the treatment of the bacterial ulcer. Okay, understood? Ram Ramji, right? Okay. Now, moving forward for the next, just a minute, guys. Just a minute. sorry for the disturbance. We are talking about it that we are not going to use the any steroid in this condition. If we use the steroid, guys, please remember about it. Already the bacteria is available over there. If we put the steroid over there, it is decreasing the immunity. We have to give the immunity to the body. That's why we are giving the antibiotic. So in this condition, the we can say the steroid is the contraindicated. Okay, so the steroid is the contraindicated. Now, moving forward, the next we are talking about the fungal corneal ulcer. By the name, you are guys can understanding, or we can say the fungal keratitis, right? And what will the cause of this infection? The fungal will be going to your cause of infection. So etiology is here, guys, the fungi, and which fungi is here? Please remember your aspergillus, your candida, and your fumarium are the common. But which is the most common? The most common is your aspergillus. Okay, the aspergillus is the your most common is. The next, what will be the your infections, like which infection are modes here? Okay, right. So what can be happen in this, that what are the infection modes over there? The infection modes are here. The infection modes are here. That is the your, that that is the your vegetative matter, right? What is the your cause of it? Guys, please remember about it, that what is the cause of it, this infection, right? That is your vegetative matter injury. What is this? Vegetative matter injury. What is the mean of vegetative matter? I hope you remember this, the vegetative matters, like there is a leaf of, or that the leaf of some tree, or maybe some the animal tails can be this, or maybe the some the immunocompromised states are over there, which are the more common of the infectious mode. Drug impacts, are the drug impacts are over there, of course. The antibiotics, please remember, disturb the bacteria fungi balance, right? And steroid turn fungi into the opportunistic pathogens. Please remember. So maybe some drug impact is also available over there in the etiology. And now moving forward for the next, which is your clinical features. In the clinical features, we have the first, the symptoms. Please remember, this all symptoms which we had talked about in the bacterial, the same are available here, but please remember the less severe. Like if I'm talking about the pain, more pain will be going to seen into the bacterial ulcer, less pain will be going to seen into your fungal ulcers. What about the lacrimation? Less lacrimation will be there. Chemosis, less. Photophobia, less. The less will be going to see. So there is the same features will be available, the same symptoms, but please remember they are very less. And please remember it is having very slow course, right? It is having the very slow courses over there. Now, talking about the sign, which are the important to identify and differentiate it. Please remember it is a dry ulcer. What do you mean by the dry? If we are touching over this, if we are touching this ulcer, it is a very dry, and we can say the leathery, right? The as we feel the leather, right? Leather is a very dry, right? So this having the leathery touch, we can say. Also, it is also in the grayish ulcer, and please remember it is having the feathery margins. As I told you in the your bacterial ulcer, that is having the clear cut margins. But what about this? This is having the feathery, like as we see the feather, right? So it is having the very feathery margins. So we cannot like mark the margins that in this area is the growing of this your ulcer, right? Also, there is a sterile immune ring. There will be going to see in the your sterile immune ring will be going to seen over there, right? There will be the seen your sterile immune ring will be going to seen. Also, if in the later stage we are going to see, there will be seen the satellite lesions will be going to see. And what is the satellite lesion? As we have a big ulcer over growing in the center, which is the fungal ulcer, right? In the later part, or in the we can say the patient is not getting treatment in the later stage, there is the some small ulceration lesions are growing in the surrounding of the main ulcer, and it seems like that we have the satellite over the side of it, right? So it seems the satellites are over there, right, in the near the earth, right? So it seems like that the satellite is over there. So this is known as your satellite lesion in the later stage of it. And also they will be going to see your significant hypopion. So what is this hypopion? Just write down here. We can say this is a pus into the anterior chamber. Okay, and I can show you in this diagram. You can see over there this fluid which is in the back side of it. This fluid is which is filled over here. This is the your hypopion. This is what? This is the your hypopion. Is it clear, guys? So this hypopion, which is the pus in the anterior chamber, which will be the significant feature of your your fungal ulcer. Now, moving forward for the diagnosis. Of course, we have to make the diagnosis of it. So for the making the diagnosis of it, we have to do the some tests. Now, the importantly, as I told you in the starting of it only, that what that there is important is the history. What kind of history is there? The history of your vegetative matter. It's clearly mentioned that vegetative matter history should be present over there. So the first of all, of course, if the patient is coming with your fungal ulcer, the patient is having what? The patient is having the history of injury with the vegetative matter. Also, maybe the patient is coming with your history of your chronic unresponsive ulcer. What is the meaning of unresponsive? The patient is saying some ulcer was there and I had some antibiotics and this thing, but it is not giving any response. It is not decreasing, right? The symptoms are not resolving. The corneal ulcer is not resolving. So that is known as your unresponsive ulcer. That is known as your unresponsive ulcer. Now, test. What test we can do? We can do the wet KH mount. Also, we can do the cauliflower white or the gram and gym size staining can be done in this. And also we can do the culture over there, which is the your Sebon's agar culture. We can do the culturation of this fungus over on this, the right growth of this. Now, of the diagnosis, now we have to come to the treatment part of it. Now, in the treatment part of it, we can give the topical antifungal, which is the your netamycin, fluconazole, or nestin. So we can give the netamycin 3% eye drop. Okay, which is the drug of choice. We can say the most commonly we are using it. Also, we can give the some systemic antifungal also in the severe cases like the it turn into the your satellite lesions, right? In the severe cases, we can give the your fluconazole tablet or the ketoconazole tablet. Okay, in a systemic form. Okay, we can give the systemic antifungals also. Now, so this is a two type of ulcer is done. The one is the bacterial ulcer, right? And the second one is your fungal ulcer. Okay, okay, done. Now, moving forward. Now, moving forward for the next one. Just a minute. Now, moving for the next one is the your acanthamoebal keratitis, right? What is this? This is known as your acanthamoebal keratitis, also known as ring ulcer. Okay, also known as your ring ulcer. Now, why the name of this ring ulcer? You guys can see over here, the ulcer is in the ring shape. Okay, or we can say the round shape. Yes, in the ring shape, or we can say it is making a round shape, right? So this is known as your ring ulcer. What is the etiology, guys? Please remember about it. The etiology of this is the organism. What organism, guys? That is your acanth amoeba. I hope you know about it. It is a parasite, right? Acanth amoeba. And you know very well, it is a free living amoeba, will be found in your soil or maybe found in your water. Please remember which water? fresh water, kind of well sea. It can be available over there also. Also in sewage, and some books are saying in the air also, right? Now, which forms which is going to infect this eye also? Remember, is exists as the your trophozoites. It exists as the trophozoite and the cyst. The both form are your can cause the infections, right? This both form can cause the your infections. Understood? Now, moving forward for the next is the your infectious mode. What kind of infectious mode can be possible over here? So in the infectious mode, you can see here, the first of all is the your contact lens users. What is the mean of it? The patients who are using the contact lens, right? The patient who are using the contact lens can be use the contaminated, which contaminated? Amoeba contaminated, right? Amoeba is there. Amoebal contaminated homemade saline is the leading to the in the Western countries. Okay, maybe they made the homemade what kind of this I'm talking about the saline. They have to put their lenses into a saline. Okay, and what they had, they made homemade saline, and which water they use for the making the saline, that is contaminated with the your acanthamoeba. Right now, as they're going to use this contaminated amoebal saline, and as they put this the same saline water dip with this your lenses, and the same lenses they will be going to use over the cornea, the acanthamoeba reach now to the your cornea and can cause the acanthamoebal keratitis. Also, there is a trauma and exposure can be possible. The mild trauma with your contaminated matter, any contaminated matter, or maybe the salt water exposure, right from the sea water we can see, and the may be possible to the muddy water are the major predisposing factors in the developing countries, right? As India, right? We have the developing countries, so this India can be possible in the come into the your water contamination or the water exposure. Now, moving forward for the next, which is the opportunistic infection. What kind of opportunistic infection can be occur? Maybe the patient is having any pre-existing corneal conditions like herpetic keratitis. The patient was having the viral keratitis already. Now, what can happen? This acanthamoeba took the opportunity and caused the acanthamoebal keratitis also. So this will be also can be the possibility for the your opportunistic infections. The next, what clinical features will be going to see over there, guys? Please mention in the symptoms, which is the your severe pain, and write down here why the severe pain. This is due to the keratoneuritis, right? Kerato, it means your cornea. Neuritis is the nerval pain, or we can say the nervous pain, right? So there will be the nerves can cause the, it can like it can damage to the nerves endings also, and that's why there is a severe pain will be seen in this patient. Also, the watering from this photophobia, the same as we have had the symptoms in the corneal bacterial corneal ulcer and the fungal corneal ulcer. Also, we have the baphlospasm and the blurred vision, and the blurred vision will be the symptoms. Now, what kind of the sign can be seen over there? In the sign, we can see the gradually worsening of the keratitis over the months with a period of remission, and limbitis. As we talked about it, what is the limbus? Corneal scleral junction. There will be the infection will be going to seen over there. Limbitis, right? A radial keratoneuritis and the advanced ring shape stromal infiltrates with the abscess can be caused into the your cornea. What can be the use for the diagnostics? Please remember, for the laboratory diagnosis, we can use the KOH mount, and in this KOH mount, we're going to find the identifying the cyst of acanthamoeba. Also, the cauliflower white stain can be highlight the cyst under the fluorescence microscope. Also, we can use the lactophenol cotton blue stain, which is visualizing the cyst over it. And the last, which we can do the culture with the non-nutrient agar, shows the trophozoites into the cyst within a 48 hours. So we can see this all the things into it. Now, talking about the treatment, what kind of the treatment? The non-specific, which is a general to the corneal ulcer treatment, like the atropine. For the pain decreasing, we can give this atropine, or we can give some systemic painkillers. This specifically for this particular ulcer, what we can give, it includes a drop like your bromide acetate or the neomycin, but the polyhexamethylene bromide, right, PHMB, it is the drug of choice for this. It is the drug of choice for the your acanthamoebal keratitis. We can give this into the into the your tropical. We can give this as an eye drop. Also, the oral and tropical imidazoles we can give for the long durations we have to give. And what kind of the long durations? We can give up to the 6 months to 1 year, right? We have to give the more prolonged use of it, right? So we have done with the what, guys? We have done with the your bacterial ulcer. We had done with the your fungal ulcer. We had done with the your acanthamoebal, and we had done with the your acanthamoebal parasitic keratitis. Now moving forward for the last one, which is the your viral keratitis, and which is also known as your viral corneal ulcers. The simply, it is also known as herpes simplex keratitis. It is also known as herpes simplex keratitis. What are the etiology will be there, guys? Please remember, if we're talking about it, the viruses. What viruses are here? This is the herpes simplex virus, which is HSV1, which is the above the vest, causing the above the vest. HSV2, which is causing the below the vest. Okay, and the most common primary reactivation by the stress, contact lens, trauma, and the sun exposure and the fever. So these are the causes of this, particularly causing for the etiology of this virus. Now, what kind of the infectious modes? The HSV1 is coming from the close contacts. As we talked about it, it is remaining above the vest, so through the kissing or the touching. The HSV2 is as coming from the lower or to the vest, below the vest, we can say. So it is from the your infected genitalia to the neonates, right? From the infected genitalia of the neonates. What kind of the ocular lesions can be seen? In the ocular lesions, in the primarily, we can see the vesicular lesions, or we can say the acute follicular conjunctivitis will be going to seen in the starting. But there is a fine course epithelial keratitis is there. The epithelial will be going to you are infected in with this. In the recurrency, recurrent it means causing again and again. We can see over there as it is epithelial keratitis. So it will be going to cause the punctate lesion. What guys mean this punctate lesion? So you can see the image number A. Image number A is showing you the punctate lesion. This is small dots, right? This punctures. This is small dots or the punctures are causing the your punctate lesion. So this is known as your punctate lesion. This is known as your punctate lesions. So in the starting, you can see the punctate lesion from the your epithelial keratitis. Over the period, it can cause your dendritic ulcers. It will be going to seen as the dendroids. I'm going to show you, and the later this dendritic ulcer will be going to join with the geographical ulcer. Joins with the your geographical ulcer. So you can see over there, it is the your dendritic. It is your dendritic ulcer, right? So you can see it seems like a dendroids like this. Okay, and the later this dendritic ulcers will be going to cause your geographical ulcer. Geographical ulcer, you guys can see over there, it seems the geography of a some land or island, or we can say the Iceland, right? So it will be going to seems like that. This is the geography. We are reading the geographical maps over here, right? And the later part, it will be going to involve the eye, and it is causing the corneal ulcer. All right. So start with the punctate epithelium, the next dendritic ulcer, and the later it will be going to cause the geographical ulcer. All right. And the next After this epithelium, it will be going to involve the stromal layer also. So it is known as the stromal keratitis. It is known also known as the deciform type of the keratitis. Right, deciform layer is also involved, can be there. So this endothelial damage result into the corneal edema, and due to there is the impression of the aqueous humor. And what kind of the shape will be going to seen over there? There will be the focal disc shape patch. Totally, there is a disc round, right? Focally disc shape patch of the stromal edema will be going to see with the without the necrosis in the starting, but later part it will be going to cause the diffuse necrotic keratitis. It will be going to cause your diffuse necrotic keratitis. It will be going to cause it. And if we are not treating this, it can be go into the trophic keratitis or can cause the your herpetic iridocyclitis. It can also involve your iris and your ciliary body, right? So it is known as herpetic iridocyclitis. For before this, we have to use the treatment of it. And guys, please remember about it. We can use the antiviral drug, which is the acyclovir ointment 3%, right, for this patient. And because the other we can use like oseltamivir and other ointment we can use if the acyclovir is the resistant for this patient, so we can use the others, right? And also the drug of choice is here the your topical steroid. So the drug of choice in the bacterial ulcer, guys, please remember the bacterial ulcer, it is your antibiotic, which is the moxifloxacin or the gatifloxacin. In the talking about the drug of choice in the your fungal ulcer, that will be the your antifungal, right? And the next, in the acanthamoebal keratitis, we have the drug of choice with the PHMB, right? And polyhexamethylene bromide. And last one, which is your viral keratitis, please remember the drug of choice is the your here the steroids. Now, moving forward for the next corneal disease, right? You clear most of the basic concepts. Thank you, sir. Sure, doctor. We are covering the basics because the basics for the your this Dinesh Kumar, come back, sir. Yeah, right. Basic is needed, right? Before the going for the diseases, we have to cover the basics, right? And mostly they are giving you the questions like clinical form also. But if you know the basics, you can crack the clinical based question, no issues, right? Through this. Now talking about the next, which is the keratoconus, guys. This is the your non-infectious disease. Okay, this is the non-infectious diseases. It is not the infectious. So what is this non-infectious disease? So let's talk about it. The definition. It is a bilateral. Please remember, it is a your bilateral corneal ectasia, right? Which is the start in the puberty of the patient and progressively, guys. Please remember, it is the progress very slowly, right? It will be going to progressive slowly. What will be the symptoms of this patient? The patient is having the progressive myopia. The patient is having always the progressive myopia. Also, not with the only the myopia, it is having with the myopia with the irregular astigmatism. And okay, if the patient is having the progressive myopia or the myopia with the irregular astigmatism, it is getting comfortably with the glasses, but the patient is here is not fully corrected by the glasses. If we give the glasses to the patient is not getting the relief or the patient is not getting the correction of it, right? Now then, what is this, guys? The symptom we is understand, no pain will be here, guys, because it is a not infectious. Okay, this is not infectious. What are the sign over here? What can sign will be seen? In the sign in the slit lamp, we can see the central thickening, right? We can see the centrally thinning of this, and with this we can see over there the Flesher's ring. What we can see the Flesher's ring, guys. So what is this a Flesher ring, guys? Just check it out. Before the Flesher ring, just I am showing you the one important sign, guys. This is a very important sign, and the PYQ is also, which is known as the Munson sign. And guys, what is this Munson sign? As I say to this patient to look downward, as I say to this patient to look downward, as it look downward, this cornea, which is the protrude, which is coming outward, like it is making cone. This cone will be going to make the impression over the lower eyelid. Can you see? It is making the depression over the lower eyelid, right? As it make the depression over the lower eyelid, as it make the depression over the lower eyelid, this is known as your Munson sign. Okay, this is known as your Munson sign. And please remember, the Munson sign is seen in the later stage. But in this Munson sign, what is happening? At the base of this cone, guys, just check it out. At the base of this cone, as I can show you here by the making this box over here, you can see in this box there is something, something is flashing back, right? So what is this? There is the iron deposition. There is a iron deposition at base of cone, right? At the base of cone, there is a iron is deposited. So now this iron, as I turn on the light in the patient's silk lamp light in the patient's eye, so this will be going to give me the reflection back, and this is known as your Fleischer's ring, right? This is known as your Fleischer's ring. Is it clear, guys? This is the your known as your Fleischer's ring. Now, moving forward. Now, moving forward for the next, Fleischer rings is done. Now, the next we can see over there, Vogart's line. What is this Vogart's line on the descent membrane? Descent membrane. Guys, what can be happen as this cornea will be going to stretch and making a cone, right? You can see this is making a cone over it. It's stretching and making a cone. So now what can be happen over there? As this will be going to stretching, as this will be going to stretching, so this descent membrane will be getting tear, right? So the descent membrane will be getting tear, and due to this, there is a Vogart's line. There will be the descent membrane, a vertical. Please remember, as is the V. Please remember, as the V, as the vertical stretch marks will be going to see. Vertically stretch marks. So you can see over here, this one. I hope you can see over here, right? This marks will be going to seen over here in the vertically in the descent membrane, and this is known as your Vogart's striae. Vogart's striae. The next, if I see on the retinoscopy, we can see the scissor reflex. As you know, what is the mean of scissor reflex? As we are taking your retinoscope to the left side, it will be going to cross over the from the right side, right? So this is known as the scissor reflex. Like at the scissor, as we are going to crossing over it, so these are crossing the same. The scissor will be going to cross over it. Okay. Also, the oil dropped reflex will be going to seen on the ophthalmoscopy when we are going to do the indirect ophthalmoscopy in this patient, or the direct ophthalmoscopy. From the distance, there will be the oil drop reflex will be going to seen over in this. Now, if I'm talking about the treatment part of this, please remember, in the early stage, we are giving the RGP lens, which is known as ridged gas permeable lenses. And what is this lenses, guys? Please remember about this. What is this importance of this? Why I'm saying this rich gas permeable lenses we have to use? Why we cannot use the normal lenses, guys? Please remember, the normal lenses is having their curvature, right? They have the fixed curvature of the cornea, but here the curvature is changed. As the curvature is changed over here, now after the changing this curvature, what can be happened? Due to the changing of this curvature, due to the changing of this curvature of the cornea, this normal lens will be not possible to attach over here. Now this ridge gas permeable lens is what, guys? This ridge gas permeable lens can be adapt, right? This ridge gas permeable can be adapt the shape of or the your curvature of the cornea. All right. So as it is going to curvature of the cornea, right? As it is going to keep the curvature of the cornea, the patient is getting relief, right? If the patient is getting relief in the visual symptoms, right? In the later part, we can do the penetrating keratoplasty, which is maybe the intact, right? And also we can do the collagen based surgery, which is known as your C3R CXR surgery, right? So these are the possibilities, the treatments of the your keratoconus. Please remember, the medical treatment is not available for the keratoconus, right? We have to do the surgical corrections only, and for this like temporary treatment, we can give the RGP lens, right? We can give the RGPD lens to the this patient, and for this we have to go with the surgical options only. We have to go with this surgical options only, right? And now moving forward for the next, which is the your diseases of conjunctiva. I hope the diseases of the cornea you don't have any doubt, guys, right? If you have any doubts, you guys can mention in the chat box. I can clear your doubts. I can clear your doubts, guys. Okay, just mention in the chat box if you have any doubts. Guys, if you have any doubts, you can mention in the live chat, right? So I can reply your queries, right? No issues. Let's move forward. If you have any doubt, you can mention over there. I can clear, right? I will going to clear you. Now, moving forward for the next, which is the diseases of the conjunctiva. But before the going with the disease of conjunctiva, let's talk about what is conjunctiva. Let's talk about the definition of conjunctiva. This is the definition of conjunctiva. Okay. And what is this conjunctiva, guys? Please remember the conjunctiva is your a translucent mucous membrane that covers the posterior surface of the eyelids. So it is covering what? As I have the eyelid is the anterior part. So posteriorly we have the posterior part of eyelid, and it covers the anterior part of the eyeball till limbus, right? Till the limbus. So now if I'm going to show you here, you guys can see over this that where this is your eyelid, guys, right? Upper eyelid, this is the lower eyelid. Okay, upper eyelid and the lower eyelid, we have the eyelids, and just beneath this eyelid you guys can see over here this layer, right, which I'm drawing over here. This is the your covering the anterior part, or we can say the interior from the inner side. It is covering the inner side of your eyelids, right? Not only this, it is covering the anterior part of your eyeball. So this is the scleral part which is covering over it, and it finished at this here. You can see, and what is this? This is your limbus. Okay, it is covering here from till the limbus. Okay, so it and at the limbus. Now there is a two thing which you have to understand over here, guys. As I told you, there is a two type of the conjunctiva. The one which is covering the your inner part of the your eyelid, that is known as your tarsal conjunctiva. That is known as your tarsal conjunctiva, and which is covering your anterior part of eyeball, that is known as your bulbar conjunctiva, right? So we have the conjunctival two parts, tarsal conjunctiva and the bulbar conjunctiva, and again the same thing as we talked about it. Of course, sir, this will be going to, right, this will be going to meet at a junction, right? This tarsal conjunctiva and the bulbar conjunctiva will be going to meet at a junction. That junction will be known as, fornix. So the superiorly it is attaching, this is known as the superior fornix. As this will be inferiorly, it will be going to attach, it is known as inferior fornix. Okay, so we have the tarsal conjunctiva, we have the bulbar conjunctiva. Also, there is the tarsal conjunctiva and bulbar conjunctiva meets over there, that is known as the fornix. So as it is attaching the superiorly, it is known as superior. As it is attaching on the inferior side, it is the known as inferior. Okay. And now, what is important about this particular conjunctiva? The mucin secretory glands, these are your goblet cell, and these glands are going to secrete the mucus which is essential for the wetting the cornea and the conjunctiva, right, which is making the your wetting of the cornea and the conjunctiva. Now, as you understand about the conjunctiva, right? As we talked about your conjunctiva. Now, if you understand about the conjunctiva, we are starting with the diseases part of the conjunctiva. In the diseases part of the conjunctiva, we are starting with the first one, which is a very important one. And what is this important one? This is known as your vernal keratoconjunctivitis, right? What it is known as? It is known as your vernal keratoconjunctivitis. And what is this vernal keratoconjunctivitis? Its short form is known as the VKC. So examiner can ask you in the short form also, like what is the treatment of VKC, or what is the most common cause of VKC, right? Can ask you anything, right? In a short form also. Also, it is known as your spring catarrh, right? So this is, please remember the synonyms also, because the examiner want to confuse you between this names only. Okay, as the examiner want to confuse you, so what it is, they are confusing you, in between this names only. The what is the definition of this vernal keratoconjunctivitis? It is your recurrent type of conjunctivitis. Guys, please remember, it is a recurrent. What is the mean of recurrent? If the once the patient is getting this conjunctivitis again and again, okay, the patient is going to get this conjunctivitis again and again. Also, it will be going to cause the bilaterally. It cannot be going to cause in the one eye. It will be going to involve your both of the eyes. Okay, write down here both eyes. Okay, both eyes. Clear? Now, and please remember, it is your allergic type of conjunctivitis. Okay, it is a type of your allergy. So, what are the three importance? This is the recurrent, this is the bilateral, and this is the allergic type of your conjunctivitis. Now, the allergic inflammation of the conjunctiva with seasonal incidents. Guys, please remember, it is a causing by the seasonal incidents. So we can say it is a your seasonal disease, right? It's come with the seasons. Now, what are the etiology of it? Please remember, the etiology of it is your IgE mediated hypersensitivity. And you know very well, guys, which type of hypersensitivity is your IgE mediated. Write down here, hypersensitivity type 1. Okay, which is your hypersensitivity type 1, right? Which is IgE mediated, right? Also IgE and eosinophils will be also seen over there, right? Now, and it is oftenly with the grass pollen. It's oftenly seen with the what? The grass pollens, right? I hope you saw in the early starting of the summers, you can see the pollens over there. So these are the grass pollens, which is going to cause this your hypersensitivity, and this is associated with the some atopic condition also. Some patient are having the atopic conditions, and this is associated with the what kind of, maybe the patient is having the allergic asthma or maybe the eczema, right? So the patient is having the allergic asthma or eczema, and the patient is also recurrently getting the VKC, vernal keratoconjunctivitis. So this is the more commonly seen with the some atopic conditions, right? What are the predisposing factors over there, guys? Please remember about it. What are the predisposing factors? The predisposing factors are here. The commonly age and the sex is the common in seen in the boys. It is commonly seen in the boys. And what age? The age of boys are the 4 to 20 years. Okay, the age of the boys are the 4 to 40. Yes, the commonly seen in the boys, guys. Please remember, this is the commonly seen. So now please remember, if there is a given randomly given a clinical case and mentioned you that the boy age is 8 year, 9 year, or 10 year, right? In between this 4 to 20, we are talking about it. The 12-year boy is coming with this, this symptoms. So by the seeing this, the boy and the age, you can identify or you can make the diagnosis like it can be VKC. But you have to find now the VKC sign, right? The sign and the symptoms you have to find in this clinical cases. Is they mentioned over there? So the answer can be the VKC will be there, right? So what are the seasons and the climate? Please remember about it. It is the more prevalent in the summers, as I told you, in the summers, and please remember in the tropical climates. The clinical forms are over there. Now, if I'm talking about it, the clinical forms are over there. So there is the palpebral. What is the meaning of palpebral? We talk about the palpebral conjunctiva and the bulbar conjunctiva. So the palpebral is also known as the tarsal. Okay, so the tarsal conjunctiva, which is beneath your eyelid, right? The tarsal conjunctiva, which is beneath your eyelid. If I'm talking about it, what will be going to seen over there? There will be going to seen a special sign which is known as cobblestone papillae, right? This will be seen on the upper tarsal conjunctiva, right? So this is the your cobblestone papillae. You can see over here. And what is this papillae? You can see over here. This is the flat topped papillae, right? This is the flat topped elevated papillae, right? Which is on the upper tarsal conjunctiva, on the upper tarsal conjunctiva, right? And this is known as your cobblestone appearance. Okay, this is known as your cobblestone appearance. Please remember, this is your image based question and your PYQ also. Previous year question they asked this, right? Previously they asked this about the cobblestone appearance. Okay, now, so on the, you can see over it, on the your tarsal conjunctiva we saw the cobblestone, right? Make a star over here. Okay, let's make a star over here. So this is the cobblestone appearance. Now, moving forward for the next one. Moving forward for the next one, which is the your palpebral is done. Next, we are talking about the bulbar. What will be seen on the bulbar features? Bulbar, which is the visibly from the anterior part of the eye, there is a some gelatinous gel-like structure. Limbal thickening will be going to seen, and which is known as your Tantas spots. Guys, please mark the important over here. Make a star over here also. Okay, this is the important, and make a star. And what is this a Tantas spot? Guys, please remember. So these are your Tantas spot. Okay, these are your Tantas spot. You can see over there, there is a limbal thickening. What is the guys limbus? I already told you, corneal and scleral junction. So these are the corneal scleral junction. You can see some gelatinous thickening. This round gelatinous thickening of this is known as your Tanta spots. Okay, so the two things on the palpebral conjunctiva, or we can say the tarsal conjunctiva, we're going to see the cobblestone appearance. On the bulbar conjunctiva, we'll be going to see what Tantas spot. Now, what about it if the type of the mixed type of the your VKC? In this, there is a feature of both palpebral and bulbar form. The both are presented over here. Now, come to the treatment part. Guys, please remember about it. What kind of treatment? As it is the allergic type of conjunctivitis. Please remember, as it is the allergic type of conjunctivitis, locally we can give the topical steroid, right? As it is the hypersensitivity type 1 reaction, as we give the steroid will be going to suppress this hypersensitivity. Also, we can give the mast cell stabilizers, right, or the antihistaminics and the cyclosporin, right? These all are the, for you can understand, this antihistaminic will be going to stop the histamine action. Okay, histaminic actions, or the mast cell stabilizer. You know very well the mast cell is secreting the histamine. So if we stabilize the mast cell, so mast cell is stabilized, so no histamine. Now there is a no histamine release or no histamine, so there will be the no histaminic reaction will be going to seen over there. Also, in the systemic form, we can give the oral antihistaminics can be given for, and the short-term steroid can be given also, right? In the short-term period, we can give the steroid also can be given. What we have to do about the large papillae? If we talk about the cobblestone appearance, they grow very largely. So we have to give the steroid injections. What we have to do? we have to give the steroidal injections, and we can do the cryotherapy. We can do the cryotherapy. I hope you know about the cryotherapy, right? Which is also known as the cold knife therapy, right? And we can do the excision of it, right? We can cut and remove this papillae, right? Which is growing over there, right? Which is enlarging over there. Now, what is the general treatment can be given? We can give the patient dark goggles as the photophobia is there. Also give the cold compressions and the environmental changes we can give to this patient. From the tropical area, we can remove this patient and go to the from the any other areas we can shift this patient. The prognosis is over there, guys. Please remember, oftenly this is self-limiting. Often it is the self-limiting, and it is resolves in the 5 to 10 years, right? It is automatically the patient is having this, but later on after this 5 to 10 years, the patient will be going to resolve with this, having the resolvement of the disease. Okay, right? So this is about your vernal keratoconjunctivitis. Okay, about your conjunctivitis. Now we are moving forward for the next is the disease which is your trachoma. We are going with the next disease is the trachoma. Very important disease, the trachoma. Frequently asked question in your medical examinations in the FMGE exam or in the NEET PG exam. They are asking about the trachoma. Now, what is the definition of this trachoma? What is the definition of this trachoma? The trachoma is a chronic keratoconjunctivitis. What is the meaning of kerato? It means that it's involved the cornea. Conjunctivitis, conjunctival. So it is the kind, we can say it is a complex disease which is a we can say which is infecting the conjunctival part also and the your corneal part also, right? So it is the your kind of keratoconjunctivitis that primary affect the superficial epithelium of the conjunctiva and the now, as it is involving, please remember, it is chronic eye infection caused by chlamydia trachomatis. So this is the your causative organism, causative organisms, right? This is the causative organism, and it lead to, please remember, it lead to inflammation and scarring. Please remember, it will lead to inflammation and scarring, and it is a potentially causing the blindness. Please remember, it is having the potential to cause the blindness. So that's why it is the blindness caused by infectious disease. Infectious disease is the your trachoma. So the trachoma is the disease, infectious disease which can cause the blindness, right? Which can cause the blindness. What is the hallmark sign of your the hallmark sign of your trachoma is your sagogane follicle. The same, it is seen on the tarsal conjunctiva as the cobblestone we saw, right? As the cobblestone was the flat topped, but it is the your tipped, or we can say the sharp elevated. We can say the sharp elevated. We can say the sharp elevated points. Okay. Now, talking about the next, which is the chlamydia trachomatis, which is the your agent for this causing this disease, and this is having some serotype. What kind of the serotype it is having? It is having the type A, B, BA, and C. Also, some other serotypes are also available from type D to K. They can also cause the your trachomatis, right? For this. Now, mode of infection, which is the very important, is the mode of infection, guys. What is the mode of infection, guys? Please remember about it. The mode of infection in this condition, the mode of infection in this condition is the direct spread. What kind of the direct spread, guys, here? Please understand about the diet spread, that it is contacted by the airborne or the waterborne, right? The directly it can be the contaminated with the patient, and it can be contacted by the airborne or maybe the waterborne. Also, what is the next type of transmission? It can be transmitted through the vector. And what is the vector of this trachoma? Through the fly, which is our house flies, right? So now what can be the possibilities, guys? Please remember. The one patient is having the trachoma, the fly is sitting on the his eye, and now it is carrying this chlamydia trachomatis on the feet of this your fly and come to the patient's which is the non-infected patient's eye. So it can cause this through the flies. Okay. The next, some material transfer is also possible. Some material transfer is also possible, and this is through the contaminated fingers. This is through the contaminated finger of the doctor and the nurse, or maybe by the contaminated tonometers. Maybe the doctor touched the patient's, for the examination, patient touched the patient's eye, and after this, this is the trachometer's patient. After this, is evaluating the next patient also by the same hand without the washing. So it can be transferred to the patient's, the doctor's hands or the nurse's hands. What is the clinical profile of this? Please remember the incubation period of trachoma is from the 5 to 21 days, right? So the incubation period is from your 5 to 21 days, is right. Now, symptoms. What will be the symptoms we'll be going to see over here, guys? Please remember the mild foreign body sensation. The patient is having the mildly foreign body sensation, and occasional lacrimation will be going to see. The importantly, there is a slightly thickness of eyelids and some scanty mucoid discharge. It is an important feature, right? The eyes having the some scanty mucoidal discharge, mucus one, right? Mucoidal discharge over there. And what about the sign? In the sign, we guys going to see in the conjunctival sign. In the conjunctival sign, we are going to see the congestion of upper tarsal and the fornicle conjunctiva. On the conjunctiva, we can see the follicles, which is known as your sagogane, sagogane follicles. Okay, sagogane follicles. Next, corneal sign. What will be seen over the cornea? On the cornea, there is a Herbert's pits. What is the mean of pit? It is a pitting sign. Okay. So what is happening? This sagogane follicle, which is over the tarsal conjunctiva, it is pitting over the cornea. It is hitting over the cornea, and due to this, there is some pitting depression, small pitting depression over there, which is the oval and circular pitted scars are there, right? Which is the oval and circular pitted scars are there, and which is the left after the healing of Herbert's follicles in the limbal area. So these are the by the pitting of, or the we can say the pitting scar of the your your Herbert follicles. Now, talking about the some treatment part, and in the treatment part or the management part, I think I hope you studied this in the PSM also, right? In the PSM, I hope you studied about this, right? PSM, I hope you studied about the safe strategy. So the safe strategy is used for the trachoma, right? Safe strategy is used for the trachoma. So they ask about the elimination of the trachoma, and guys, please remember about it. The trachoma is eliminated now from India, right? Please remember about it. The trachoma is eliminated. Okay, but from the overall period of it, they are asking about this. What is the this safe strategy? So please remember about it. The S, which is the stands here for the surgery. The A here stands for the antibiotic. The F is stands for here the facial cleanness, and E stands here for the environmental improvement. So these are your safe strategy, which is used for the elimination of the trachoma. Elimination of the trachoma. Let's talk about the management of it. Let's talk about the management of it. For the management of it, guys, please remember if we're talking about it, the using of it, the management of this your trachoma, we have to give this in the depending on the situation. There is a two type of the thing. Like first, which is the active trachoma. Active trachoma, it means the infection of this chlamydia trachomatis is going on, right? So the infection of this trachomatis, chlamydial trachomatis is going on. So we can give the topical therapy, which is the 1% tetracycline or the erythromycin ointment for 4 days, 4 times a day for the 6 weeks. Also, the systemic dose, the systemic therapy we can give the tetracycline or the erythromycin 250 mg 4 times in a day, or the single dose of azithromycin, which is the drug of choice. Azithromycin is the drug of choice for the trachoma, right? We are giving of it the single dose, okay? Or we can give the some combined therapies. What kind of combined therapy? We can give the severe cases, we can give the topical and the systemic. So we can give the both one, topical and the systemic antibiotics, right? So this is known as your combined therapy, right? Talking about the prophylaxis, what kind of prophylaxis, which we talked about it, the prophylaxis is the, we can give the hygiene and sanitation, or we can say the safe strategies also for this prophylaxis only, okay, the safe strategy. And early conjunctivitis treatment should be done. And the last one, which is the blanket antibiotic therapy. What is the blanket antibiotic therapy? If we are having or we are traveling into the area where is a trachoma is a very more common over there, so we can take the prophylaxis medicine, that is known as your azithromycin, right? Which is covering as the blanket antibiotic therapy, right? So it will be going to cover up and help us in the prophylactically. We are taking this medicine before the disease causes, right? As you know very well, what is the prophylaxis? The prophylaxis is before the having the disease. If we are taking any treatment, that is known as the prophylactic treatment, right? So this is about the prophylaxis. And the safe strategies, please remember, for the management or the we use for the elimination of trachoma. Okay, as I already told you, the recently updated, the trachoma is eliminated, right? The trachoma is your eliminated. The next, we are starting with the next, which is the your pterygium. This is also your conjunctival disease, but please remember, this is the again non-infective. This is again non-infective disease. It means this is not any infectious disease. Okay. Now, what kind of this disease is there? Please remember about it. A wing-shaped, guys, what is happening in this particular disease? There is a wing-shaped fibrovascular growth. What is happening in this patient? There is a wing shape, like a wing is growing over there, like a wing shape fibrovascular growth is there, and fibro means some the outer layer, which is the scleral one, right? We can say sclera, fibrous layer is that, and vascular. It is having the vascularity also. The fibrovascular growth of the conjunctiva that extends onto the cornea. Guys, basically, I already told you the cornea is and at the limbus. You can see in this patient here, this conjunctiva is ended here at the limbus. Yes, it is not extending the limbus. And please remember, the conjunctiva is not covering over the cornea. Why not covering? Just listen this part. In the definition only I told you. What I told you? In the definition I already told you that the conjunctiva is what? The conjunctiva is your translucent membrane. What is this? This is your translucent membrane. As it is the translucent membrane, guys, please remember, translucent, there is a no transparency, right? As it is a translucent membrane, if it is covering over the cornea, is the cornea will remain the transparent? Not remain the transparent. And as it is not remaining the transparency, how the patient will be going to visible and how the refractive media will be going to visible. Guys, please understand this thing. So that's why your cornea is not covered with, please remember, your cornea is not covered with the conjunctiva. Okay, so your cornea is not covered with the, your cornea is not going to cover with your conjunctiva. Now, very good, moving forward. But what is happening in this disease, pterygium? There is a cornea conjunctiva will be going to overgrowth, and this fibrovascular growth will be going to cover the cornea. So you can see this fibrovascular growth is crossing the limbus and covering your cornea, right? The typically it is from the nasal side. Please remember, the most commonly it is from the nasal side. So the patient is having this pterygium mostly from the nasal side, right? It is growing from the nasal side, like from the right side also, on the left side also, the nasally. What kind of appearance will be going to seen in this patient? The appearance of this is your patient is having the triangular or wing shaped fold, right, of the tissue, often start near the inner core of eye. Okay, so it start from the inner core of eye, which is your middle canthus, and you can see over here from the medial canthus, it is the middle canthus, right, which we can say the inner corner of the eye. It is starting from here and extending on the cornea. Okay, it's starting from over here and extending over the cornea. Next, what can be the more seen over here? Now, if I'm talking about it, if just I'm erasing with this, what can be seen over here? It is having the three part. This pterygium is having the three part, right? What is this part? The first one is the head of pterygium, and here near the limbus it is having the neck, and the last one is the tail part. Head, neck, and the tail. And what can be seen over there? There is a sometime there is a deposition of iron will be seen sometimes on the corneal epithelium, which is the anterior to advising the head of pterygium. So near the head of pterygium, if I'm drawing here, so I'm removing this head, right, and drawing with it, like if there is a pterygium head is having like this. Okay, there is a deposition of iron over here, right? So this particularly is sign is known as Stocker's line. This particularly sign is known as Stocker's line. Okay, so please underline this Stocker's line, and guys, please reply me in the chat box. Earlier also we saw in the keratoconus. In the keratoconus, we saw the patient is having a iron deposition in the cone, that is known as Fletcher's ring. Guys, please remember that is known as Fletcher's ring. Okay, now that is known as Fletcher's ring. What about this? What about this, guys? That is, this is known as your, just a minute, I think audio is going more. That is known as your Stocker's line. That is known as your Stocker's line. Very good. Now let's move forward. Let's move forward. And now moving forward with the symptoms of it. Guys, what are the symptoms of it? Guys, please remember about it. The redness of eye. You can see over it, the eye will be getting redness. The secondly, there is the foreign body sensation. There is a foreign body sensation. The patient is having the irritation in the eye in this, and due to this foreign body sensation, there will be the watering. Okay, these are the common symptoms, right? Pain will be not here there, but in the later stage, in the later stage, it limits the eyeball movement. Okay, so what can be happen? So it limits the later stage, it will be going to limit the eyeball movement. So it will be going to limit the eyeball movements in the later part. All right, now what can we give in the treatment? Now we are moving forward for the what we can give in the treatment part of it. Guys, So please remember it. The treatment part, there is a no medical management is possible for this pterygium. We have to give the only and only surgical excision of this pterygium. We have to cover the surgical excision of this pterygium. In what kind of condition we can give this? If the patient is having the cosmetic concerns, right? The patient is saying, I'm not looking good, or my eyes is not looking good due to the pterygium, so we have to do. Also, there is a progression towards the your pupillary area, right? If it is covering this papillary area, wait for the crossing of it, so there is a visual disturbance will be going to seen, so we have to do the this. Okay, due to this visual disturbances, we have to do this. We have to do this excision of this pterygium. Or maybe the patient is having the feeling the diplopia due to the interference of the ocular movement. As I told you, it will in the later stage, it will be going to limit the eyeball movement. So in this condition, we have to do. But please remember, there is the thing. If we only do the only excision, or we can say the only simple excision. Write down, guys. If we do the only simple excision, there is a 70% chances of recurrence. So for stopping this recurrency, what we can do, we can give the drug mitomycin C. It reduced to the 40% of corneal recurrence of this pterygium. And if we do corneal, if we do, if we do here after the excision, if we do the conjunctival autografting, if we do the conjunctival autografting, after the doing this conjunctival autografting, there is the very less, we can say the less than 5% chances of reoccurrence, right? So this is the topic of the today's we covered in the part 1 of ophthalmology. Now the rest of the topics which we have left and we have to cover up, we have to cover up the cataract, we have to cover up the glaucoma, we have to cover up the neuro-ophthalmology, and the last some diseases of the retina which is important for it, we are going to cover up in the part 2. Okay guys, so if you have any doubts in the today's session, you guys can directly contact me on the Instagram. My Instagram handle is the Dr. Vaibhav Ahuja, right? Dr. Ahuja. And this PDF of this session will be available on the Telegram channel. Please remember, this session of this PDF is available on the Telegram channel of Meduhub. All right. Okay, guys. So this is a part 1. We are ending this part 1 here only. We are going to take one more part of this. One more session of this ophthalmology for which is known as the part 2, right? So we covered the basics here only, and the rest of the diseases like the glaucoma, cataract, and the neuro-ophthalmology will be going to cover up in the part 2. Okay guys, thank you so much and best of luck for your preparations. Goodbye.